Welcome to another episode of Cutting Edge Health. If we haven't met, I'm Dr. Orlando Landrum, and today we're talking about seniors and depression. We're having a discussion about who does it affect, why it affects them, how it causes challenges and issues, and more importantly, what to do about it. One of the reasons why we're brokering this subject is very frequently seniors are pushed to the side, and sometimes how they feel and how those feelings impact both them and the people that care about them or themselves really isn't talked about. It's very stigmatized. And there's a number of different elements in the media and other pieces that have very much marginalized that, and to some efforts made kind of, light of it. Things like the following. So when we take a look and we really try to assess what's going on, sometimes we get kind of stigmas, things like this, but she's an old lady. Look at her. She's old, as Adam Sandler says, right? And actually, depression that's present within the elements of individuals who are older in nature is pretty prevalent. When we look at a number of different studies, and one of the things that we can kind of see is the following. Is that a prevalence of major depressive disorder is pretty prominent. Most people think about it, in youth and between ages of 18 and 25 being prominent. But even though that's a decreasing trend, as you can kind of see in this particular graph, it's actually more prevalent than what one might think. And so what we end up seeing is things that kind of look at depression is not a normal part of growing older. And a lot of times I think it's an assumption that's made that is indeed the case. But there's a number of reasons for why an older individual may have different feelings of hopelessness, of guilt, of restlessness, of loss of interest, fatigue, difficulty concentrating, insomnia. Some of those things are kind of a blend of depression. And when we look at numbers specifically for seniors, what we end up finding is the following. Is that those individuals who are greater than 65 plus years of age, that 1 in 15 have some degree of depression, and about 10% of those actually get help. However, 20% of suicides per year are for people 65 and greater. And that's significant in nature. And it's one of the things that we want to kind of be able to address and make people aware of, because not everyone is really leaning into understanding the challenges that are faced. And so first, we want to be able to kind of identify who is it that actually is involved and it has some of these challenges and issues. And then within that construct, what can be done about it, right? So when we take a look, one of the things that we want to be able to kind of identify is who are these people that are having these challenges? And some of them are the following: is individuals have had risk factors that have had issues with major depressive disorder, certain combinations of medications, individuals that have had damage to the body, whether it's been secondary to amputation, cancer, whether they have fear of death, whether they've been socially isolated, whether they have other illnesses, whether they have chronic or severe pain, whether they have a history of depression, and things that cause you to be at increased risk. Or if you're a female gender, if you don't have a social support, if you are have an increased stressful life events, and things like if you've had a stroke, high blood pressure, you have a rhythm problem like atrial fibrillation. If you're diabetic, you have a history of cancer, dementia, or chronic pain. As you kind of see, there's that overlay that we've talked about multiple times of kind of that element of physical pain with sort of that mental anguish and cognitive type suffering and pain and emotive feelings that are present. So those two things kind of go hand in hand, and frequently in traditional allopathic medicine, we try to separate them out. But knowing those things help us identify who is the who in those populations that are senior and have risk factors for depression, so we can be better attuned to being able to hopefully figuring it out and being able to render treatment. When we take a look at how to be able to kind of address that, it can be a little bit tricky. So one of the things that if you're an advocate for a senior is to really be aware of what's going on with them in terms of physical limitations and knowing how to be able to have a conversation that's going to make a constructive input as opposed to being combative. And so talking to seniors before they do dietary changes or new activities that may stress their ability to really be functional is something to have a discussion. How to be able to make sure that you're respecting their individual preferences, and really how to be able to have some degree of tact and reading the room and having some emotional intelligence on how to be able to have that conversation. Sometimes that's useful by having other individuals help join in that conversation. But at the end of the day, it's an element that really needs to be evaluated and assessed, right? On how to be able to have that conversation with seniors. So we've kind of identified the who to an extent, but we're going to get into that even a little bit further by talking about screening and what are some of the screening tests that you can kind of be able to look at. So a good number of patients that have pain can have depression that's associated with it. And that's certainly the case for seniors as well. So about 25 to 50% of seniors have some degree of pain that's associated with it. And what ends up becoming frustrating is this element of treatable but not curable, and doing different modalities and things where you're assessing patients for things that we have to do. We have to assess them, for whether there's certain treatments are going to be potentially at risk and causing problems and issues. And the same token that we assess for physical risks, there are different screening tools that clinicians, not just physicians, but nurse practitioners, physician extenders, other individuals can be able to assess patients for their degree of risk, both for things that predispose them towards having depression, but also having other things that contribute to depression. So different scales and tests that can be assessed are things like the MoCA test, things like the Stop Bang test, things that can be able to be evaluated. In Psychiatric Times, the journal, they looked at a couple different things about how to identify and tackle that who, right? And one of the things that they make mention of is that treatment-resistant depression is pretty prominent. That's in nature. It actually affects anywhere from 60 to 40% of the geriatric population. And so in getting some clarity about that, what we know is that it increases morbidity, meaning sickness, mortality, and just as talked in that last couple slides ago, suicide. And so patients can frequently have depression that's significant, and it can come back, meaning it recurs for a good number of patients in about 40%, and it's continuous in another 25 to 35%. So one of the ways to really kind of be able to take a look at identifying this is having treatments be evaluated by a traditional behavioral health individual. Prior to getting to that, many times people would like to know what are some of the symptoms that they can help either their loved one or themselves in identifying, is this depression or is this something else? And so some of those symptoms are things like the following. So persistent feelings of sadness, loss of interest in activities, whether they have trouble sleeping or oversleeping, whether there's some degree of appetite or weight changes, whether there's fatigue or decreased energy, whether there's difficulty thinking clearly or quickly. And I think some of those things are kind of challenging because people will say, well, maybe there is an underlying physical reason for why individuals might have that. And we're going to talk about the actual why for why some of those things occur, but referring to depression and what's the molecular mechanism or basis behind it to an extent, but it can be multifactorial. But identifying that who, as we made mention of before, there are things like restricted mobility, if they're isolated from family members, if there's a shift from work to retirement, whether there's financial difficulties that exist, if they have issues with confronting mortality, which many of us do, whether there's death of loved ones, whether there's divorce or widowhood, whether there's substance abuse or misuse, which I want to kind of address. Most people really kind of think that seniors don't misuse medication. They do. They most certainly do. And to be able to have a frank conversation and identify that is something that needs to be discussed. If they're remembering the good old days, and chronic medical conditions can be things that can cause problems and issues as well. Okay. So there is a paper that looked at how to be able to assess this from a molecular standpoint. It's the following paper, and it's a molecular basis of late life depression, actually published in the International Journal of Molecular Sciences. It gets fancy really quickly, but we'll kind of break this down and be able to kind of understand it a little bit better. But basically, the text kind of gives you the following, is that it's caused by the metatropic receptors that are present, which are part of the glutamate receptor, G protein coupled receptors. And they have a number of different things that have been suggestive of causing depression. But at the end of the day, it may be secondary to some aspect of those glutamate receptor subtypes, MGL2, MGL3, and those things have also been associated with increased inflammation. So I know a number of individuals will say, well, hey, maybe diet modification might be able to improve things, and it might be. But one of the things that they have seen is that cytokine levels not only increase with age, but it also decreases serotonin. And so those type of things can have factors. So if we're to look at this in kind of a cartoon pictorial representation, it looks in the following way. So you have the signal pathway, which is secondary to different receptors like the NMDA receptor and AMPA receptors that have substrates of things like sodium and calcium that come in. And then they have this G protein response that results in a cascade that can be likely to cause problems and issues. So I wanted to give an understanding that this isn't just a touchy-feely woo-woo type sensation, but there's actually science that has shown that there's reasons for why depression actually occurs, particularly in seniors, and some of the mechanisms behind how that actually happens. So when we talk about this type of impact, it not only impacts seniors, but it impacts the healthcare system. And it's something that really, again, needs to be looked at. And so one of the papers that looked at that is the following, is an evaluation of the clinical and economic burden among older adult Medicare covered beneficiaries with treatment-resistant depression. So some of this is looking at how the system is affected, and some of this is looking at how patients are affected. And normally, many seniors are on a fixed budget. As you can see from many different commercials, they say over and over again, I can afford this brace because I'm on a fixed income and I need to make sure that it can be able to work. But in all truthfulness, this is very much the case. So when you look at how depression can be affecting seniors in the healthcare system, this paper broke it down into a number of different metrics. So the dark bar is treatment-resistant depression. The gray bar is non-treatment depression, and the other is non-major depressive disorder. And what you can be able to kind of see and make out as you take a look at this graphical representation is really the following. Is you can be able to pick out that one is hospital stays and two is ER visits. And you can see that the dark bar pretty much leads in both inpatient stay as well as in regards to hospital visits. And that is significant in nature because the costs that are associated with that, as well as the bar on the far right-hand side that looks at length of stay, is longer for those depressive elements that seem to cause more challenges, more problems for individuals than not. And that ends up becoming an issue. And as we would kind of gather, that is some of the things that sort of result in the quote unquote how, in terms of how these things impact patients in a fairly adverse way. So we look at true raw data, what we see is the following, is we see that there's a fair amount of spend that takes place when we look at inpatient costs for those people that have significant depression, which is difficult to treat in the geriatric population. You can see a $9,000 spend versus those that don't have depression of $4,000, an outpatient spend of $3,000 to $1,000, ER costs that are $330 to $217, outpatient costs in clinic, which are going to be $5,000 to $2,000 spent, pharmacy costs of $5,000 to $2,000, and a total overall cost they're going to be $24,000 to $8,000. So some of this is going to be through insurance, surely, but some of this may be actually directed towards a patient. So we talk about a threefold cost that's levied on seniors because of difficult to treat depression in relationship to their other chronic conditions, that's a huge thing to really kind of have to deal with. In addition to that, there are other sequelae or other problems that can result. And that same paper showed the following, is that treatment-resistant depression can have adverse drug reactions. And for those patients that have just traditional treatment-resistant depression, you can see as the number of drug adverse reactions can occur are significant in nature, particularly 2 to 3 to 4 over a period of time, and multiple different issues can occur because they're dealing with medications like antipsychotics and anticonvulsants, which end up causing all kinds of challenges that if we were able to identify and look at different strategies, may be able to provide some degree of benefit sooner than not. So one of the questions that comes up is, why does this happen in the first place? Why are we not identifying some of these things? And if we were to be able to identify it, what can we do to be able to hopefully be able to provide people some degree of value? And one of the things that takes place is nearly 2/3 of Americans who are 65 or older who are concerned they have depression will not seek treatment. 61% will say, you know what, I'm just going to tough it out. It's going to be okay. And as you can tell, there's a number of reasons for why that shouldn't necessarily be the case. Not only costs, but there are issues that result because those things aren't being treated. So that begs the question of the following, is what can be done, right? And we talk about what can be done. There's a number of different therapeutic options that are out there. But one of the papers that looked at and tried to assess this was some of the fancy type of treatments. Things like, if we're reading this, is the efficacy and safety of esketamine, also known as Spravato, which is a nasal ketamine type treatment option, right? And it was like, okay, well, maybe for seniors, this might be a good treatment. But when we take a look at it, it doesn't turn out to be. What they found is that for those individuals that are older than 75, is that it didn't make as much of an impact. For those individuals 65 to 74, it was able to treat depression, which is its main indication. And it was able to provide people relief that had onset of depression less than 55. But for those greater than 75, it wasn't necessarily the best result. So what can we do in order to make seniors really feel like they are truly living their golden years? And that kind of harkens back to an older TV show called The Golden Girls, where you had individuals that were old but still lit, or you had individuals like Sophia that are just so cool, right? That we can be able to find ways to be able to make them feel better. And some of those different things are going to be the following, is you can be able to look at SSRIs as a potential treatment option. It doesn't always work. There's some downsides to SSRIs. There are different medications that are in play for this, right? There are other treatments that you could consider, but they typically have side effects. So TCAs and SNRIs and MAOIs traditionally have things like headache, upset stomach, insomnia, anxiety, restlessness. So some of the things that can be confounded for depression itself. So what are some of the treatments that may be able to provide some degree of benefit? Well, they're going to be things possibly like psychotherapy. And historically, considering doing therapy for a population that had difficulty being able to get to and from sessions have been challenging before in the past. But the fact of the matter now, with the advent of being able to use technology and individuals who can be able to help leverage that technology for them, it may not be as difficult and may be of value. And the second one is one that has been controversial and really been stigmatized aggressively in media and film, and that is the use of ECT, electroconvulsive therapy. Where ECT has changed a lot, particularly in the last 10 years, but what they've seen in a good number of studies that have been shown over multi-centered evaluation is that ECT has been probably one of the most effective treatment options for difficult to treat depression. And in the senior population, it's outpaced things that have been unproven, things like ketamine, which many clinics do, including my own, as well as TMS. ECT has been beating out some of those different treatments in terms of being able to give good relief. So we want to make sure that people know their options so that way they can be better, because what we want to be able to do is to make sure that patients know their options, that they can be able to fulfill the things that they really want to be able to do and lead a life that's really giving them a good experience that's happy, that's valuable, and that's not being limited. And many times seniors just really are marginalized, and it's not being evaluated on the case of why are they having a problem, who is it affecting, and what can be done about it. And this is hopefully an initial starting strategy for people helping to be able to identify how to be able to do and all those different treatment measures. For those of you who are joining us for the first time, we really appreciate you joining us. Please hit the like and subscribe button. And for those of you who follow us with consistency, we really appreciate your support. And hopefully we can be able to answer other questions and issues that might come up that you're interested in. And please stay tuned to another episode of Cutting Edge Health, how we teach you to be able to punch pain in the face, whether that's physical or emotional, and get back on your feet and leading the life that you deserve. Thank you so much for joining us, and have a great day.